It is my pleasure to introduce our moderator, Dr. Jennifer Ortham Murphy, who is the Assistant Professor of Neurology at the University of Pennsylvania. Dr. Ortham Murphy will be moderating a panel on addressing the challenges of diagnosing APBD. And Dr. Murphy, the floor is yours.
Great. Thanks so much for having us and having this panel. The subject has come up many times over the past 2 days, and I'm kind of excited to dive into it because we have a lot to learn. I just want to share my experience with this challenge and why I've ended up diagnosing and taking care of people with APBD. So I am I've trained as an MS specialist or neuroimmunology specialist, and a lot of our diagnosis is based on brain MRI. And here I'm showing you what's called a normal adult MRI, where the white matter is actually this dark gray area here, and the fluid of the brain is black. And we like to look at that sequence of MRI because in MS, the lesions show up as these white ovoid lesions that can kind of show up all over the place, but often very near to the center fluid-filled areas called the ventricles. But sometimes we see people that have MRIs like this on the right, where all of the white matter is affected on both sides equally in the front and the back of the brain. And that pattern is just not typical for MS. So what do they have and what do you do next? And it turns out that as a fellow, I decided to sort of think about how I could do genetics evaluation of people that weren't fitting that MS diagnosis. And adult onset inherited white matter disorders are pretty similar to progressive MS because there's progressive motor issues, weakness, dysarthria, dysphagia, gait ataxia, bladder, bowel, sexual dysfunction, cognitive impairment, and decline in spasticity. But things that don't overlap are when other systems are affected. So if you ask about eye issues, endocrine issues, or if there's peripheral neuropathy, and I've highlighted here APBD, because we do not expect to see a peripheral neuropathy in MS, as well as skin findings and other systemic findings, then the sensors go off, the red flags are something else is going on. And so a few years ago, when I started here at Penn with my own clinic, I sort of put down my own flag and said, I'm going to have an undiagnosed white matter disease clinic and send me anyone who doesn't fit a diagnosis of MS, headache, or vascular disease, or has a family history of a similar disorder, has already had an MRI and sort of the typical workup, and we'll see what we can find. And so I work with a genetic counselor. In fact, I work with Aaron Baldwin, who's here on the panel today. You'll hear more from him. But for everyone that we evaluate, we do counseling for the patient and the family. He generates a family tree. We get insurance approval for the test we decide to send, and hopefully test multiple people if we need to. The types of testing that we send are variable, and it's not a one-size-fits-all approach. It really depends on the story presenting in front of us. You can do targeted gene sequencing like in the GBE1 gene, but I actually do that only if we know of family history because of the availability of next generation sequencing panels like hereditary spastic paraplegia or leukodystrophy panels, or even more broad, our whole exome sequencing and whole genome sequencing that are now increasingly being covered by insurance. And so whole exome sequencing has the advantage of that it's now looking at all the exons, which is still only 1% to 2% of the genome. The reported findings are usually only on genes we know to look for. And you've heard before that the variants can be reported as pathogenic, likely pathogenic, or variants of uncertain significance, and we have to work hard to figure out what to do with that. You need to do this with genetic counseling because you can find incidental findings like medically actionable conditions like BRCA, consanguinity, or non-paternity. So people like to know about that ahead of time. The benefits to this is that you can look at many genes at once. It could be cheaper than doing one gene at a time. And even if you don't find an answer the first time, you can reanalyze later as we get smarter. The disadvantages is that it's not the whole genome. You will not see deletions, duplications, and I highlight here intronic mutations because we heard yesterday that that is a cause, a mutation in APBD, and we're going to miss it with this test. Whole genome sequencing extends the coverage to coding and non-coding regions. But as we also heard yesterday, it doesn't necessarily capture those deep intronic mutations. So it's not a perfect test yet. The timing for the analysis is very long and it's not always affordable quite yet. So we're getting there, but we're not quite there. But in the past 3 years of me establishing this clinic, I've sent testing on 58 of the patients I've evaluated. Most of the testing has been whole exome, some of it panel, and even more rare were the gene testing, because the approach we had was, what is the most comprehensive and cost-effective test? Well, we're not really sure because it's not fitting any known phenotype. And over this time, our approach actually changed because Invitae sponsored their, or someone is sponsoring the Invitae leukodystrophy panel. And they've, since April 2021, I think this has expanded from about 300 genes to 700 genes. And GBE1 is included on this panel, as mentioned yesterday. And so of this cohort, I've diagnosed about 22% of the people with an inherited white matter disorder who otherwise would not have had a diagnosis. Importantly, that leaves 3/4 of them uncertain because we don't know how to interpret the results, or we can't, and there's various reasons for that we're not going to go into today. And we can't just rule out an atypical MS based on the findings. But importantly, the most common diagnoses I've made are adrenoleukodystrophy, which is the most common of the leukodystrophies, all rare disorders, a CSF1R related leukoencephalopathy, and APPD is the third most common diagnosis I've made. And I've made these diagnoses by whole exome sequencing. And so looking at what we've learned, just to let you know, to sort of educate others in my specialty, is now that I know what APPD looks like and why it's not MS, what are the features that distinguish that? But, and we'll talk a little bit more about this, and that APPD doesn't really have the inflammation that you see in MS from the peripheral immune system, and you should not see a peripheral neuropathy in MS. But as I've heard over the course of all the large and small meetings I've been to in the past 2 days, there are so many ways that people have come to finally get to their diagnosis. And I've listed some of the options here. You could be with a neurologist or neuromuscular specialist if you're primarily presenting with neuropathy, which according to that Columbia Natural History study, most of the people in that study had neuropathy as their original diagnosis. Or a multiple sclerosis neuroimmunology specialist, a neurogenetic specialist, a neuro-ophthalmologist was mentioned at the last panel I was on. It could be asymptomatically diagnosed as part of pre-pregnancy planning with a genetic counselor, or you have a known family history and you've been sent to a genetic counselor, or a medical geneticist, or maybe a urologist is concerned about why you're coming to see them, or a physiatrist or PTOT, and maybe others that you can help us understand who we need to educate. So that I'm really excited to welcome this panel of people that I've actually worked with and have sent me patients, because they are incredibly gifted clinically, and I learned from them, and we learned together about how to diagnose and help others be able to diagnose APPD so that we can get to the next steps. And so I have invited Aaron Baldwin, who is a genetic counselor who works with me, Dr. Kristen Edmondson, who used to be at Penn, and is a neuromuscular specialist at Swedish Medical Center, and then Dr. Joseph Berger, who like me is an expert in multiple sclerosis, but also world-renowned in infections of the brain, and has spent much of his time teaching young neurologists how to find those diseases that are mimicking MS. And so with that, I will stop sharing, and I would like each of you, and I'll call you out by name, to start by introducing yourself, your primary area of expertise, and how you were introduced to APPD. And so I'll start with you, Dr. Berger.
Sure. So I don't pretend to be an expert on APPD. I started my academic career in HIV. Looking at patients that have neurologic complications of HIV. And then when I became a department chairman at the University of Kentucky, where we didn't have an MS specialist, but a lot of MS patients, I expanded the breadth of my interest and ran the MS clinic there for 20 years. And I've been very interested in the mimics of multiple sclerosis because very often unusual patients are sent to me, largely because I'm probably the oldest person in the department, so I've seen a lot. And as a consequence, I see individuals that don't fit neatly into a diagnostic category, and people ask my opinion as to what it may be. So my experience with APPD is largely in the MS clinic, where I'm seeing people that are known to have disease of the white matter from their MRIs, but a diagnosis has yet to be established. It's not clear what it is. I mean, in some instances, it may be MS, you're not sure, but in others, it's clear that it's not.
Thank you. Dr. Edmondson, can you, coming at it from a different perspective?
Yeah, absolutely. So I live in a little bit of a different space within neurology than Joe and Jen do. I'm a neuromuscular specialist, primarily evaluating and treating folks with disorders of the peripheral nervous system. You know, and certainly there are some of the manifestations of APPD fall within that realm. So I see a lot of patients with neuropathies. We do a lot of ALS diagnosis in my area of expertise, and certainly that is one of the mimics. My experience with ABPD primarily comes from my work with Jen at Penn, actually. You know, I'm sure as we go on, we'll talk a little bit more about sort of what those differentiating features are between some of the more typical neuromuscular disorders that we see frequently, and the, you know, what sort of red flags might make us think that someone could have something like APPD or, you know, another inherited or atypical rare disorder. So, you know, I'm primarily a clinician rather than a researcher. And I think, you know, the role of someone like me in this disorder is really knowing that it exists, understanding the red flags for it, and understanding how to help patients access more definitive diagnostics.
Thank you for that. Okay, Aaron Baldwin, please share with us your journey to APPD.
Hi, everyone. Thanks again for having me today. I'll talk a little about my background. I'm actually a recently graduated genetic counselor who started right up with Dr. Orthman's clinic in the leukodystrophy clinic. And I can admit that through our graduate school training and neurology learning in graduate school, we didn't really go over this condition. It wasn't, you know, a common enough condition to be covered by a lot of graduate programs. So my introduction to the condition was through the leukodystrophy clinic with Jen, and making some diagnoses through whole exome sequencing and some of our panel-based results. And so that's how I've kind of got involved and learned more about the condition. So thanks for having me, and I'm excited to be here.
Awesome, thank you. All right, so we'll go around again. And this time the question is, based on your experience, either one or more patients, which, you know, in the general scheme of things, I know you don't feel like an expert, but actually if you've seen it in many cases, this makes you an expert. What were the clinical features that made you think that the person who was ultimately diagnosed with APP did not have one of the disorders that you commonly diagnose? So we'll start with Joe.
Well, I actually prepared a little slide presentation. So if it's okay, I'll throw it up on the screen.
Sure.
Let me see. All right. Yeah, so sorry about that. Can you see, do you see my screen?
Yes, we see it.
Okay, all right. So these are obviously people that are seen by me because they've come in with the thought that maybe they have MS. And these are a couple patients that I saw here at the University of Pennsylvania. One was a woman in her late 50s who had presented with progressive clumsiness that had developed 15 years earlier. She was of Ashkenazic Jewish descent. Her symptoms initially had been quite subtle when they started 15 years before. And then she developed occasional imbalance that worsened over time to the point that she found it difficult by the time she saw me in climbing stairs. In addition, she complained of a sense of leg stiffness and nocturnal cramping in her legs. She had no other symptoms that would suggest MS. She was sent to me with the thought that maybe she had MS. She didn't have any visual symptoms. She had no bowel or bladder problems. She didn't complain of vertigo. She had no electric shocks going down her spine when she bent her neck. And importantly, her spinal fluid was perfectly normal. However, one of the other tests we do in MS is we look at whether or not individuals have problems with their optic nerve conduction. And she had abnormal visually evoked potentials, with a quite prolonged P100, what's called a P100, on the order of 132 and 134 milliseconds. And she had, because they were concerned that she had a leukodystrophy of some sort, she had, as reported to me, genetic testing for white matter disease that was negative. And as you heard from Jen, you know, depending on what the test is that you do, that could very well be negative. And when I saw her, she had significant cognitive problems. She had poor attention. She had poor color vision, indicative of the optic nerve problems. She had spastic weakness in her lower extremities and a scissoring gait, and absent vibratory sense to the knees with positive Romberg. And this was her MRI. So the MRI shows sort of the symmetric white matter abnormality that we just talked about. The distribution is not particularly suggestive of multiple sclerosis. That's not to say that it couldn't be, but it's not very likely. And that, coupled with a slowly progressive course and the spinal fluid that was pristine, suggested that there was likely something else going on. And in thinking about her, one of the thoughts I had was maybe she had adult polyglucosan body disease. And in fact, I said, look, you need to be evaluated by a geneticist and we need to do some additional studies. She was lost to follow up thereafter. I don't know whether she ever followed up with anybody, to be honest with you. But a few years later, her brother showed up in my clinic. Now, you know that you're dealing with a genetic disease. And he had weakness of hip flexors and numbness of his legs to his knees that he thought developed after a motor vehicle accident. And it was progressive thereafter. He also had tingling in his hands, particularly his right thumb. He had some problems with his bladder and occasional incontinence, but no change in his bowel or sexual function. And on examination, he had some problems with his memory. He recalled only 2 of 5 objects over 5 minutes' time. His language and speech were normal. He had some difficulty reading color plates with his left eye. His eye movements were fine. He had a spastic ataxic gait and weakness in his legs. He had incoordination on heel to shin testing and on finger to nose testing. And his reflexes were absent at the ankles. This gets to the point that the peripheral nerves are involved, and diminished at the knees. So for somebody with multiple sclerosis, you don't anticipate that. You expect to find brisk reflexes, and instead he didn't. But in addition, he did have Babinski's, so it's obvious that he had upper motor neuron findings, as well as a superimposed peripheral neuropathy. And he had very diminished vibratory sense at the toes and difficulty standing in tandem. And he had an MRI that was quite similar to his sister's, with these diffuse white matter hyperintensities, some mild atrophy of the brain and the cerebellum, as well as of the upper cervical spinal cord. His spinal cord, which isn't always normal with APBD, happened to be normal in him. And we did a variety of studies, and ultimately, I sent him to Jen for further evaluation, thinking that this was going to be APBD, and that indeed is what was demonstrated. So MS is a clinical diagnosis. I mean, there's no specific test that we have that says you have MS. So it's really a constellation of things. We have revised our criteria. Some of you may be not terribly familiar with the terminology in MS, but we have several forms of the disease. There's a form of the disease called relapsing remitting disease, which is what we see in about 80 or 85% of people. It's usually a young woman between the ages of 20 and 40, though it needn't be, who comes in with something acute that's happened to them. And these are the criteria that we now use. There's been an evolution of these criteria, and it incorporates the clinical evaluation with the MRI. You need to have both dissemination in time and dissemination in space in order to make the diagnosis, and you need to rule out anything else that may look like it. So in the absence of doing that, you can't call it MS. You can make the diagnosis without MRIs if you have 2 or more attacks and they're clinically documented with objective findings. But generally, we rely on the on the MRIs and on spinal fluid examination. Now, we don't mistake APBD with relapsing remitting disease. Where it can be mistaken is with another disease called primary progressive multiple sclerosis. And primary progressive multiple sclerosis accounts for maybe 10 to 15% of all MS patients. And in this particular illness, the person develops a gradually progressive problem. Typically, it's a problem with weakness and stiffness in the legs that progresses over years, but sometimes they have other features like cognitive impairment or visual problems that accompany it or develop progressively. And these are the criteria that are used. Now, it turns out, with the exception of the abnormal spinal fluid, it doesn't really help you distinguish it from APPD. And the differential diagnosis for multiple sclerosis is really quite broad. There are inflammatory disorders, vascular disorders, neoplastic disorders, infectious disorders, mitochondrial disorders, metabolic disorders, among which are the adult polyglucosan disorders, mechanical, miscellaneous, ophthalmologic, and psychiatric, that can all give rise to MS. So to a diagnosis of MS, a mistaken diagnosis of MS. We've gotten better at diagnosing MS, so we now are diagnosing it more quickly, as demonstrated in this study from 2005. It used to be that it would take sometimes years to make a diagnosis where you'd feel comfortable, but now with the MRIs and the spinal tap, et cetera, we make the diagnosis a lot earlier. The current estimate of misdiagnosis is actually 5 to 10%. So a fair number of people that are being treated for MS don't have it. And in fact, in autopsy studies, of course, performed at a time when we didn't have the sophisticated tools that we have, the diagnosis at autopsy was incorrect in a third of individuals. And I'll just say that just because you happen to be fellowship trained in MS doesn't mean that you're not going to miss the diagnosis from time to time. In this particular study, 24% of neurologists that had made an incorrect diagnosis of MS actually had been trained in an MS fellowship, or their practice was focused on it. So MS is frequently overdiagnosed, and that's a common diagnostic error, generally due to an uncritical reliance on the MRI and a hasty workup. And in these instances, people with adult polyglucosan body disease can be easily misdiagnosed.
Thank you so much, Dr. Berger. That was great. I think we'll get back to that a bit more, I think. Dr. Edmondson, I guess I'll let you in parallel talk about your experience as well as how you approach the typical and atypical approach, atypical presentation.
Absolutely. So I do not have slides prepared, unlike Dr. Berger. But in terms of my experience with APBD, it's really been the patient who was ultimately diagnosed, who I saw as someone who was sent to me for evaluation for ALS. A gentleman in his early 60s who had been hospitalized some months earlier, about a year earlier, for a UTI. And then after that hospitalization had sort of a decline in gait, maybe some memory changes, was seen by a local neurologist who noted that he had atrophy of the intrinsic muscles of his hands, noted him to be hyperreflexic, and sort of saw that combination of upper and lower motor neuron findings, raised concern for ALS, and then referred the patient to me. So, on its face, that sounds like a pretty concerning presentation for ALS, which is, unfortunately a very common disease. And on my initial visit with this patient, I actually shared that concern. His exam showed atrophy in several muscle groups in the hands and in the legs. He had mild weakness and then marked hyperreflexia. The sort of, his MoCA, I think, was around 24, so low, but not extremely low, which in certain forms of ALS, there's an overlap with FTD. So that continued continued my clinical concern there. I did note that he had mild distal sensory loss at his first visit, which, neuropathy is incredibly common. We, see sensory loss is not typically part of ALS presentation, but we certainly see people who have ALS and have neuropathies for other reasons. And then there's also sort of a differential diagnosis for ALS-like diseases that present with sensory loss as well. So one that really jumps out is Kennedy's disease, which is an inherited disorder of the lower motor neurons that's associated with a sensory neuropathy. Now, Kennedy's patients certainly don't have hyperreflexia, which this patient had. Hereditary spastic paraparesis is another disease that typically, I'm sure there's been lots of discussion of that as being on the differential for APPD during this conference. So that, that's something that we'll often look into when patients present more with upper motor neuron findings and then distal sensory loss. And, with any patient who's coming in for evaluation for a disorder of the motor neurons, like as with MS, motor neuron disease or ALS does not have a single definitive diagnostic test. It's a clinical diagnosis that you make based on physical examination findings, based on the exclusion of other disorders. So we always MRI the neuraxes of patients who we're considering a diagnosis of ALS in, and then we often, almost universally, perform EMG nerve conduction studies. And for this particular patient, it was the EMG nerve conduction studies that kind of first raised my hackles that this might not be ALS. They had, as I expected, given some mild distal sensory loss and neuropathy, which didn't particularly bother me because, like I said, neuropathies are super common. But what I found was that the denervation changes that I observed on their EMG were mostly chronic. Right? And in ALS patients, what you really look for is acute and chronic denervation changes across multiple myotomes. So the fact that he had this very chronic denervation without a lot of active changes sort of pushed me towards wondering, is this something else? Then his neuroimaging was also problematic. His MRI, if you see someone presenting with hyperreflexia and intrinsic hand muscle atrophy, we always look for cervical disease. Cord compression along with radiculopathies can mimic ALS. And this patient actually had some not insignificant degenerative changes, but it was not affecting the lower cervical myotomes, which is where one would need to have disease in order to get weakness and atrophy of the hands. And then, the big clincher was that when we MRI'd his brain, he had severe white matter disease. And that was the point at which I thought that this patient probably had something hereditary and probably needed to see Jen. He'd actually, I believe, come to me already having had very long chain fatty acids done and having been negative. So that being, I guess, a slightly more common disease than APPD had been my first thought, but had already been looked at. So to sort of summarize the things that would make me as a neuromuscular specialist differentiate APPD from motor neuron disease, some of it is the constellations of associated disorders. So significant neuropathy, significant memory loss might or might not, but certainly not seeing acute changes on EMG and seeing significant CNS process would really push me away from a disorder of the motor neurons. Typically, the neuroimaging in motor neuron disease is normal or, only just some very mild abnormalities along the corticospinal tracts, and certainly not the kind of white matter changes that we would see in APPD. From a neuropathy perspective, it's a little bit trickier. Like that might be a harder way into a diagnosis, partly because neuropathies are so common, and partly because and Jen and I have been talking about this a little bit, partly because the genetic testing that we will sometimes do for neuropathies, for a large part, does not include GBE1. So, if you send a hereditary neuropathies panel on someone, most, if not all of the time, that's going to miss the causative gene. So I think that, from a neuromuscular perspective, certainly if someone is coming in with a neuropathy, the red flags that this just isn't just a garden variety neuropathy are going to be many of the sort of clinical characteristics that have been discussed. So hyperreflexia, right? A neuropathy patient shouldn't be hyperreflexic unless they have a B12 deficiency, which you could readily identify on the standard screening labs that we do. And then certainly cognitive changes, bladder changes, family history, all of those things are going to be red flags that might push me in the direction towards an evaluation that would turn up APPD as being causative. And I think really the most important thing from a neuromuscular clinician's perspective is to know that this disease exists and have it included on the differential for similar diagnoses. Like anytime I'm thinking about adrenomyeloneuropathy, anytime I'm thinking about Kennedy's disease, anytime I'm thinking about hereditary spastic paraparesis, you just kind of need to flag that APPD could present in a similar way so that it's even on the table. And if genetic testing is pursued, ensuring that the relevant genetic tests are included.
Thank you so much, Dr. Edmondson, and for bringing up the fact that if someone presents with a neuropathy, that both of us look today, it is not on the neuropathy panel. So yeah. Aaron Baldwin, I'd like you to comment now. There's two issues that we've experienced. So I have a two-part question for you. One is, what happens when people really don't have any symptoms, but have learned about that they carry these the homozygous or heterozygous recessive mutations in GBE1? How do you approach that discussion? And then when we're considering testing generally for people presenting to our unknown disorders, either via neuropathy or leukodystrophy, how do we get to the right test?
Great. And I think that's a great question, Jen. And one thing that I'll note just before diving into that is something that Dr. Edmondson noted, which is that family history can be really important in thinking about this condition. Specifically, it's a recessive condition, so it's very common for each side of the family to not have any symptoms or anything that adds up to this kind of diagnosis in the family. So I think that's something to kind of keep in mind here. In terms of thinking about our atypical versus typical presentation approach for testing, we consistently will do a leukodystrophy panel for any patient with any kind of white matter differences seen on MRI. But again, when we start to see some of these additional symptoms, things like progressive muscle weakness, urinary incontinence, again, is something that's commonly seen in this condition. It makes us think maybe to do broader testing, which could include whole genome sequencing or whole exome sequencing. And I think, again, speaking to Jen's point about the panels, they've changed. And when we first started looking at genes that had to do with leukodystrophy, GBE1 was not a gene that was included on many of those panels. I think our first diagnoses came from a whole exome sequencing, and since then it's been added to many of those leukodystrophy panels to be seen and hopefully noted for patients. But it's a tough conversation to talk to a patient who has come back to us with usually a surprising diagnosis after not having any family history of a genetic condition. And it can be, quite a difficult conversation in talking to them about how this impacts them and how it could impact, their lives moving forward as the disease progresses, but also in thinking about other family members that are also at risk and need to be evaluated. So I think for one of our patients, one of the clues that we had, especially looking back retroactively, was that he had a sibling who had very similar features. She also had some differences in her gait. She had some urinary incontinence. And those all started in her 40s, which are around the same time frame for APPD. So it was really important and helpful for us to see there was a family member who could have also inherited that recessive condition from both parents. And so it can be a surprising conversation for patients, but it's really important for us to have that conversation to not only raise awareness within the family so that other patients and family members are aware that this gene or this genetic cause is running in their family line. And so they can do carrier testing and their own kind of testing to follow up and make sure everyone else is as healthy as possible. So that would be my background on that.
So with all of this in mind, I noticed that both Joe and Kristen said, so they sent to me. So what do you think? So not everybody has that set up, right? So what do you think are the barriers to getting a diagnosis of APPD, and how do we go forward to overcome that? So I'll start with Joe.
Well, I think the very first barrier is to think about it. I mean, it often doesn't show up on the radar screen. So it's got to be put on people's radar screens. It's like anything else that occurs rarely, but is very important to recognize early. And so I think education is an important component. And that means we've got to educate the people that are likely to see individuals with APBD, which include the neurologist, the ophthalmologist, the physiatrist, and others. And it's got to be more than just a back of the textbook presentation. You know, some diseases are so rare, as Aaron mentioned, that they're seldom mentioned when you go through training. And, you know, I think that we just have to highlight it. Now, I attempt to do it when annually I give at least once a year to a large audience a course on mimics of MS. And I always try to incorporate one of the individuals that has a genetic disorder that's presented with MS, because that gives me entree to talk about APPD as well. So to me, the first barrier is that. And then once you think about it, once you know what it should look like, and you're not always certain that that's what it is. I mean, until you get the genetic analysis, you don't know. And I will tell you that when the first person I saw that I was telling you about today, I'd written in the note, I went back to look at the note, it's been 7 years now. I said, if this person on MRI shows contrast enhancing lesions, I'm going to change my thinking. You know, maybe she has primary progressive MS, right? Because you don't expect to see that with APBD. Well, she never went for any additional studies, and we found out from her brother that the diagnosis suspected was correct. So, so I think, you know, the first is to think about it, the education, and to know where the resources are to be able to get the genetic testing, because I'm in a unique situation, and I suspect Kristen is as well, where she is, that, you know, you have the resources available to you, but there are many instances where the resources are not available to you, right, because right, you're practicing in a small community, or you're practicing, there may be states without the adequate resources in this country.
Dr. Edmondson, what do you think?
Yeah, so I agree with everything that Joe has said. I think that, you know, as I prepared for this panel and thought about some of these questions, you know, one of the things, like I said, that Jen and I noticed is that this gene, GBE1, is not on any of the hereditary neuropathies panels. It's actually not on many of the hereditary spastic paraparesis panels as well. Like a quick review turned that up to me. So, you know, so
we have to fix it.
Yeah, exactly. So I'm like, who can we call? So GeneDx had it on their panel, but I think many of the other companies that I often work with don't actually have it on their HSP panel. So we're entering an era of genetic testing where we can do so much more. And I think clinicians are starting to do more. Right. I definitely miss being at Penn, where we had access to fantastic neurogeneticists, genetic counselors like you, Aaron. Where I am at Swedish, while it is a large neurology group of 100+ neurologists, we don't have a dedicated neurogeneticist, right? I can send them to sort of, there's some geneticists in the OB department, but really it falls to me to do the genetic testing. And I think more and more, especially with the sponsored panels, community neurologists are directing genetic testing, you know, where they say, oh, you have a weird neuropathy, I don't know what this is. I know that like Invitae or another company has a free panel. I have this stack of boxes in my office. I can just swab someone's mouth and do some genetic testing. So I think, you know, from an advocacy and awareness perspective, having the gene included on the panels for the diseases that there's overlap in presentation. So it would make a huge amount of sense, I think, to me, that, you know, companies try and include GBE1 on their HSP panels, because, you know, you think about the presentation of the hereditary spastic paraparesis, lower limb dysfunction, difficulty walking, hyperreflexia, peripheral neuropathy, right? They're the complex HSP patients with peripheral neuropathy. So, you know, certainly the white matter disease you're not going to see, but I think sort of along with having it on a clinician's radar is having it embedded in the diagnostic process of other similar diseases, so that it can be picked up and identified, even if like that clinic, you know, a neuromuscular neurologist who isn't aware of it and has never seen it, or even, you know, a community neurologist who's kind of taken an interest in this patient and trying to send off some genetic testing before they refer them to a major medical center where maybe they can't get an appointment for 6 to 12 to 18 months, right? So that they're trying to do something on their own before getting them to that other resource. Sort of having the gene embedded in the places where it might be picked up earlier.
Erin, what sort of resources can people look to get access to testing and genetic counseling that are maybe, you know, people will send 23andMe testing sometimes, but, you know, some of the companies actually have genetic counseling backup. Where might someone get diagnosed alternately?
Yeah, absolutely. I think one way, there is a Find a Genetic Counseling tool on the NSGC website, which is the National Society of Genetic Counselors. You can actually search by zip code to try and find a genetic counselor in your area who would be able to kind of speak to the complexities of the genetic testing that might come with this kind of condition. So I think that's really important just to think about in terms of patients that might be disconnected from, you know, a robust neurology program where they can, you know, sufficiently do genetics and genetic testing and follow up and all those measures. The other piece that I'll speak to is kind of piggybacking off Dr. Edmondson's comment, just raising awareness and getting the gene covered on different panels, whether that's a neuropathy panel or any other panel that might include some of the symptoms that come along with APBD. One other, you know, addition to that is to think about carrier screening. You know, it's very common in genetics for patients to do carrier screening before pregnancy just to see if there are any genetic causes of a condition that both they and their partner may carry. GBE1 is starting to be added to many of these carrier screens, which I think is really important in just raising awareness of that carrier status before a child or another family member is diagnosed with the condition, and just learning about it through that carrier screening or knowing your status at that point can raise awareness in general and hopefully, you know, help with this patient population moving forward.
Great. Well, I really appreciate these answers. There's actually, and discussion, this has been great. There are a few questions in the chat that I would like to bring up. I'm gonna take my, take a first pass at the first question too, but happy to have anyone join in. So Dr. Kaplan asked, has anyone observed evidence for neutrophil infiltration and or neuroinflammation in APBD? In basic research, people do perform neuroinflammation tests in mice. Is there a correlate justification in APBD patients? I'm so glad you asked this because this is what I'm working on the clinical guidelines to sort of discuss what we know and what we don't know about that. And so I think what it comes down to are two things, like how are you defining neuroinflammation? There's compartmentalized inflammation, meaning the role of microglia and astrocytes in responding to injury in the brain, which is, or in Schwann cells in the peripheral nerve. And we can immunostain for that in mice and in pathology, either with biopsy in the nerve or in autopsy tissue. In APBD, at least the MRI does not have evidence that there's a leaky blood-brain barrier and leakage of gadolinium into the brain. So we don't suspect that things like lymphocytes are leaking in, but I don't think we really know if things like macrophages and other innate immune cells are going in because we actually don't have the tools, even in pathology and mouse models, that actually distinguish sometimes microglia from invading macrophages. And so because that toolbox is only being built right now to be able to look in mice, we really don't know in people. However, there are markers for PET imaging that look at macrophages that could potentially be done going forward for studies. And there are different types of high resolution MRI techniques looking at different maybe astrocyte metabolics or microglial markers that are being developed. I don't know if anybody else wants to jump in on that.
I forgot to add to my question also gliosis.
Yeah, yeah. So gliosis, again, is sort of this, we're only kind of understanding what that means. So there's this kind of explosion right now that reactive astrocytes by GFAP staining is just like, you know, step one to notice that the astrocytes are participating in the process, but really doesn't tell us what they're doing and how they're influencing, impairing, or promoting any sort of repair. And again, the toolbox is being developed to look at that in our animal models and then to develop back to people. And then the other question that I see here, as we're running out of time, is that does anyone have any experience with getting genes listed on different panels from Dr. Verma? And Dr. Ackman said that he convinced, I think, 23andMe to include it on their chips. So that is awesome. Thank you for doing that.
No, we did with Jeff actually, right? We had lots of meetings. I mean, that's just the logistics. So all those panels actually, they are pre-made. So if you want to include, they have to use up the ones that they have unless it is very significant financial issue.
Yeah, and I think, there's many other issues related to this going forward that we obviously don't have time to talk about today since it's already 3:15. Happy again to take any questions going forward. I would really like to thank Dr. Berger, Dr. Edmondson, and Aaron Baldwin for joining me today for this discussion, which I think we can certainly expand upon in the future. And thank you all for coming.
Sure. Our pleasure.